So we're going to have the panelists come up so that you can ask questions. So be thinking about all of the wonderful things you want to ask these very knowledgeable women.
Hey, Julie. I loved your video on the access of the RICM catheter. So we use Omayas at Stanford currently, and we access them with butterfly needles versus a port needle. So I'm just wondering where you came up with that procedure.
So our lead neurosurgeon is the one that initiated that procedure using the larger needle, because he wanted to make sure that we weren't traumatizing any of the cells on their way in. We use a butterfly needle on the day after T cells are administered for our collection of, we do CSF collection afterward. But we use the Omaya, what's it called? Human needle.
Yeah.
For the actual T cell administration. It's just a larger gauge. And
what gauge do you use?
21.
21. Okay. Thank you.
Thank you so much for those excellent talks. I have a question on the GMP side. That was an excellent slide about all the operations in GMP. And I'm just interested in finding out what the volume might be and the capacity of that unit, number of staffing. Do they work long shifts because of the manufacturing of the cells and the availability of the patients? Because sometimes those could probably operate 24 hours. So if you can give a little bit of perspective on that, I'd appreciate it. Thank you.
Yeah, thanks for your question. I think that's a good question. I think that's something that we are also fighting like every day to try to maximize. Right now, we're a staff of 12, so we can have 6 teams currently. We can do two products per room at a time. Like I said, we house 4. In addition to the GMP manufacturing itself, we're actually also prepping the cells that are going to go in for the brain infusions. So that takes another team. So capacity is really, really hard to tell. I think last year we were projecting for this year closer to 100 products for the year. And that's full manufacturing. That does not include like patients being dropped in for that initial. We also do like an initial portion, freeze, and then thaw them later for full production. So yeah, maybe about 100. Right now our staff is 12 and we're hiring. So yeah, we're hoping to get closer to, I think, 15 to 16 manufacturers to have 8 teams. Now keep in mind that GMP facility that we work in, like I said, there's 6 production rooms. We house 4 at the moment because there's other work going on. There's also another GMP facility where they do work. They do have some T cell work, but the CAR T is really primarily in the building. And of course, space is limiting. There's only 4 rooms. So does that answer all your questions? Hours of operation. Right. So on the days that we get the products from the donor apheresis center, some of the patients do have to have a line placed, which means that our products actually come to us a lot later, like 4 o'clock. So then we ask that team to shift their hours later. Otherwise, we primarily are Monday through Friday. Some Saturday work has to be done. And we're primarily, I would say, on the days that we're doing full productions, our team can get there as early as 8 in the morning and is done hopefully by 6. On the days for T-cell infusions, our team can get there as early as 7:30 in the morning, but that is a half a day production. And of course, sometimes patients like, so it is basically an 8-hour day starting around 7:30. Right now, we only have 1 shift. So we do kind of have people kind of swing around based on that. Was that everything?
So I have a question from online. How do you navigate the differences between protocol and institutional standards for central lines?
So, I mean, whatever the protocol says, we have to do, right? We used to do all our fresh products via filtered and then our frozen products non-filtered. That's recently kind of changed. Did you say lines or tubing?
I said lines, but I mean, tubing is actually, I say go with it because this is also, I feel like, a very hot topic as well.
So, I mean, kind of whatever the protocol mandates, but sometimes the protocols don't make sense to me. So then I'll go back to them and ask, what did you really mean? And I try to follow standard of care as best as I can for the type of tubing and for the line. We used to always do, we never ever did any type of infusion on a pump. We always did it via gravity. That has recently changed, and we've started to do fresh infusions, autos and allogeneics on pumps, which is much easier. I know some people are shaking their heads like, why did you do that? But that's just how our practice was. And, sometimes things never change. And then CAR Ts are never, ever, ever on a pump. They're always via gravity. And then the tubing, we used to, never did infusions through ports. We recently started doing infusions through ports. So now we do it through a port, any type of PIC, valved, non-valved, or any type of Hickman line. And basically whatever the protocol says, we will go with. But if it says it doesn't matter, then we will try to do it just via standard of care so that we just follow our current practice.
All right. Any other questions in the crowd? All right, go to the other one on my phone. What does a typical day look like for a patient who comes in for treatment? I think that's for Julie.
So if they're coming in as an outpatient, I can speak to that, and if Sarah wants to do an inpatient. But if they're coming in as an outpatient, as I spoke in the presentation, we see them early in the morning because we need to have the labs resulted. We need to have a lot of information to make sure that we're going to be able to prep the cells that day. And we need that early so that we can get it to the manufacturing area and they can start thawing those cells. So we see the patient usually at labs at 7:30. We see them at 8 or 8:30. Sign everything off, and then send our manufacturing papers over to, or T-cell release papers over to the production area, where they will pull the vials for the day. They don't want to thaw them until they know the patient has met all the criteria to receive the cells. So they thaw the vials, do the testing, and all the background things that go on. There's a lot of communication between the research nurse and the manufacturing facility throughout that day. Lots of text back and forth telling us what's happening. If there's a problem, they give us heads up so that we can give the patient a little bit of a warning that, maybe don't come at 1 o'clock, come at 2:30 instead, because there's a delay. So we do a lot of communication throughout the day to know what's happening with the cells and keep track of them. Then the patient will return at the time that the cells are expected to be ready. We prep them in the infusion facility and deliver the T cells. Ours is a push, so it's a quick infusion, and then they stay for monitoring afterwards. And usually they're really anxious about that the first day, but they recognize that because with my patients, they're repeated, so they come back once a week. So they're anxious about it the first day, but after they see that process and it's just repeated every week, they become really comfortable with the routine. We then have them come back the second day for a follow-up visit where we will do labs again, and we'll check for any toxicities they may have experienced, and we do CSF collection on that second day as well.
So I can kind of go into the inpatient perspective. So when patients come in for T-cell infusion, so they're usually admitted, if not a couple days before for the lymphodepletion, then they'll be admitted at least a day before. So we never admit them the day of, because that would just be too chaotic. So we admit them, usually the night shift nurse it's really nice here. They have treatment plans that they'll release, which have all of the orders. They'll draw whatever labs we need beforehand. So if there are any research things, we try to get everything done kind of overnight beforehand, so it can be ready for the teams when they round in the morning. So then kind of one of the biggest obstacles for any type of cell infusion that we do is usually just getting the provider to give the okay. They can give us a verbal okay, but it doesn't mean anything until there's an order in Epic. So that's kind of one of the biggest barriers, is trying to get the may give order from the providers. Because once we have that, we can coordinate with the stem cell lab to come up to create a time for when we're going to do the infusion for the patient. So typically we try to prep the patient, let them know ahead of time kind of what the day is going to look like. We never know the time of the infusion until the day of. Once we get that order, we can work with the providers in the stem cell lab to get that going. And then we usually give the pre-medications about 30 minutes beforehand. Once the lab technician comes up to thaw the cells, we'll do it right at bedside. We go through the patient disappointment that the bag is so small, it's so clear, and it contains that many cells. Yes, it does. Then they usually go to sleep because of the Benadryl. We give the product and then you just kind of wait around to see if there's any CRS or neurotoxicity. Usually doesn't come for at least like until maybe the night of or a couple of days later. But the process is usually very smooth. Even with our research nurses, when we do inpatient research infusions, the nurses are really good about coming up, talking to the nurses, making sure that, you know, we feel comfortable and we have all the tools and everything that we need.
All right, we have another question from online. This is for Dara. Those study checklists are very, very helpful for the infusion nurses as well as for you yourself. Do you have an overview of study I totally messed this up. Hold on a second. I should have read this beforehand. For the infusion nurses as well as for you yourself to have an overview of study activities. Do you also create checklists for screening activities?
Yes, we still do paper source docs. I know that probably super ages me, but we don't have a good CTMS system that allows us to keep track of everything on an online database. So we create paper source, and that paper source for the screening would have everything, but that's our internal documents. We don't share that with the study, with non-study staff. And the screening source is usually like on the back end, something that we're doing. But I am exploring the option of our standard of care BMT nurses have a evaluation checklist, you know, that includes everything that needs to happen to prep the patient for allo CAR T or autos. And I've been exploring with just taking that and modifying it and incorporating the required screening tests for the clinical trial. But that's kind of a lot of work and I haven't done it yet. So I just communicate with the other staff that has hands on that patient to make sure everything gets done. So long answer, no.
All right.
Kelly, I have a question back here from online as well.
Okay, go ahead. We have another one online, but we'll.
So Dara, I think this is for your Epic snapshot. What location is the information included in so that it can be centrally located and accessible to all the teams, nursing, pharmacy, et cetera? Or is the access limited to a certain discipline?
As far as I know, everybody has access to the snapshot. I know everyone, EMR is such a pain, I think, sometimes because everyone's view is a little bit different, but snapshot for us is, you know, just a tab at the top next to chart review. I don't know if that's the same for you guys, but anybody has access to the snapshot and not everybody feels comfortable going in and playing with the information in there. Everyone feels scared because mostly only infusion nurses use it for communication or some of the outpatient nurses. So I took over it a little bit and started putting our clinical trial stuff in there. So nobody messes with it. Nobody plays with it. And as far as I know, everybody can see it.
Okay, great. Well, there is another question, but that is going to be answered at a later time. So if there's no other questions from here in the audience, that will conclude Module 1.